The conundrum the therapist faces in advisor's level of doing in ALS MND. Thanks, Helen.
Thank you very much. Thank you for inviting me. You will notice that I'm not from Argentina. You will notice on your programme that I was supposed to be on at 9:10. 7 hours later, I'm here. So I changed with my colleagues from Argentina. So it's a pleasure. I fell asleep for the whole of the day. No, I didn't, everyone. I'm here. So you all know about professional itches. The question that you have, that you think, that doesn't quite fit with me. Why is this happening? And you see practice going on and you think, I'm not quite convinced about that. So I'm going to present to you in a very clean manner my professional itch. My professional itch has luckily been able to give me PhD fellowship funding. So I'm going to throw it out here today and hope that you've got my email and you can give me feedback for what I've said. So I'm going to be a little bit challenging in this presentation. And hopefully, when the PhD finishes and I start my intervention in January, we might know the answer. You'll all have been asked, how much should I do? People with MND, ALS say, how much should I do? What do you think? You've probably been very much like me and not quite known the answer. I come from three worlds, three perspectives. I'm an occupational therapist, so here's my clinical perspective. Here's the team that I work with. I've got an honorary contract in Chester and I've had 22 years working in neurology. I come from an educational research perspective. So I lead the occupational therapy subject area and I have a research background. Here's the most important perspective. My dad had motor neurone disease. Unfortunately, I work in clinical area. I know what motor neurone disease is all about. And then my dad has motor neurone disease in 1998. Unfortunately, it's given me quite a unique perspective to look at professional itches. That's my son there that he's with, and that's a few days before he died. As you can see, he's quite active. My son does look quite rotund. I can assure you I didn't feed him too much, but anyway. I was busy caring for my father. Okay, so this is the question that you get asked. How much should I do? So I'm going to take you through a bit of a journey, a clinical reasoning journey. First of all, we're going to look at the evidence. Evidence in utilising activity in MND. We're then going to look at contemporary practice internationally. Yes, you're all involved with this. Those of you that were here at Milan, you cannot criticise my presentation because you added to it 12 months ago and gave me some examples of case studies. We're then going to compare frameworks. We're then going to look at applying a rehabilitation framework to MND. And then I'm going to propose cautious change in practice. Let's look at some of the evidence after extensive literature searching that I've done. Physical activity, now this is all in mice. I've become an expert in mice in the last 12 months, but this is mice. Physical activity is not demonstrated as being detrimental in survival rate. Physical activity, it's saying, does no harm. Debatable, but that's the evidence that we're coming out with. Neuroprotective effects activated when mice engage in moderate exercise. I'm not talking endurance exercise, we're talking moderate, mild to moderate exercise. But there is a detrimental effect on high-intensity endurance exercise. So what we're saying is mild to moderate exercise is highly suggested that it could have a positive effect. Okay, you're saying, that's mice. Let's look at humans. Now, the evidence isn't really there as convincingly. But we know there is a positive effect for moderate exercise. Those of you will now be thinking, this could be well-being, this could be positivity. This doesn't mean the actual activity of exercise. Whatever the reasons is, positive effect for moderate exercise. Study has said it maintains function at 3 months. It improves gait function and aerobic work capacity. It has the capacity to improve functional ability. All of these positive aspects to actually doing exercise. On top of that, as an occupational therapist, we look at activity all day, every day, engaging in occupation. The need for us to achieve and do is innate to us. It's what we always want to do. It relates to our survival. We know from studies within MS, within RA, stroke, Parkinson's, that doing something purposeful improves our well-being. Pushing ourselves to do improves well-being. We also know it achieves our best level of functioning. But we haven't done this within MND. We don't know this yet. We don't know whether it would replicate the same effects. But we do know also that choice is important. So having a choice in what you do has a big bearing on your well-being and your improvement in function. Let's look at what we do at the moment. Now, we is like the royal we. Some of you may sit and go, no, I don't do that. But from what I see, especially within UK practice, is a preoccupation with therapists, with occupational therapists, for compensation and rest. A referral comes in from somebody with MND and ALS, and immediately we look at how they can compensate for doing things, rather than encourage them to enjoy the journey of actually doing. So we focus on the end task. We focus on provision of equipment and adaptation. We focus on telling them to do it differently, do it simpler, do it so they're not breathless, do it so they're not using any muscles. And we talk a lot about fatigue management. My thoughts on this contemporary practice within UK at the moment is it's quite reductionist. I'm probably not surprised that we only see somebody once or twice because we've just given them equipment and then we've not seen them again. It's cost effective in staff time because quite often doing this isn't rehabilitation time. We're not seeing each other as frequently. I've spoken to lots of people that work in clinics that say they literally see the person that comes back to clinic every so often. Prevents engagement. It's risk averse. It's safer to do this. Focuses on fixing problems. There's an assumption the condition can't be changed. The journey of doing is actually dissuaded. And it denies probably what we're thinking their previous lifestyle was. It ignores some of the stuff, and I can bore you for hours on the physiological adaptation within the cells when exercise happens. But it ignores the studies that have looked at that. But from what I've told you in the last two things, it actually doesn't follow current available evidence. I'm proposing we look at a more rehabilitation framework. At the moment, if somebody's referred to you with MND ALS, we don't consider it being in a rehabilitation forum. It's not really an option that we think about. In a rehabilitation framework, there's incremental steps in achieving a goal. There's a challenging the system through doing. And there's a meaningful change by doing something. So, I really want to be able to do this. Let's see, let's give it a go. Let's challenge the system a little bit. And by doing that, there is a physiological change that allows an improvement. If we compare the two approaches, let's see compensation on one side compared to rehabilitation to the other. Compensation, an encouragement to rest the system. Rehabilitation, an encouragement to challenge the system. Compensation, the focus on finishing the task. Okay, you can't do all of this. The carer will help you with doing those bits. It's important that you actually manage to get dressed, not actually that you have gone through the exercise of doing that task. In rehabilitation, the framework, the focus is on doing during a task. Compensation, the focus is on rest. In here, the focus is on the actual journey of doing. I put it to you that with a compensational framework, the physiological change isn't produced, but we have a chance within a rehabilitation framework. So here we were last year. I had this little itch, and I spoke to quite a lot of you about it. To begin with, quite a lot of you said, no, rehabilitation doesn't fit quite. But then when we actually talked about patients that you had treated, and you went, well, actually, you've got a point there, because this person tended to push themselves a little further and actually did achieve more through doing that. And you gave me quite a few case studies, and I give you quite a few examples of where that actually did happen. In the beginning, in a pilot study that I've done 2 case studies that have given me permission to speak to you about them here. Here, the person closest to me, we have a gentleman that continually challenged the system. He continued wanting to do. So he would actually encourage himself to keep moving. He would actually dress himself, probably not the easiest way, to where he was a little bit breathless and he was moving his muscles to a mild to moderate range. All of this is using the mild to moderate aerobic and muscular activity to a mild to moderate range. Not chronic, not tiring out, but just pushing a little bit through the system. He is convinced, and I must admit, I am a little convinced, that doesn't sound too, you can tell I'm saying cautious change, that actually helped to plateau his systems for a period of time. You can see the other gentleman next to him, Bill. As you can see, you can tell for his upper limbs that you can see from his hands that you see some wasting. You can also see a little bit of change in his lower limb. He's actually just completed the Snowdonia. And if anybody knows Wales knows Snowdonia, they are quite big mountains, Snowdonia ranges. And he's just completed the Snowdonia Marathon when we took that picture. Obviously, that's not looking that is the same for everything. But again, the perception of wanting to challenge the system and actually doing that. So, I put to you recommendations for cautious change. That we look at applying moderate exercise to mild and moderate symptomology presentation. Not chronic symptomology, but mild to moderate. So people that are presenting to us with mild and moderate symptoms, we look at probably helping them to challenge the system through moderate exercise. In my work as an occupational therapist, that would be doing this through function, through doing activities. So guide moderate challenge of the system through aerobic and muscular resistance, again, for mild to moderate symptomology. I'm suggesting that we apply the pure compensation approach where we adapt, we allow complete rest, we provide multiple equipment only to people in chronic symptomology. And we have that thought that we can do rehabilitation with people that are not presenting as chronic symptomology. And we focus upon client-centred goals. We will all know that if we want to do something, we feel a lot better by doing it, not actually being told, you're actually best not doing it, and here's this piece of kit that will help you do a bit of it. And that our intervention as OTs, rather than focusing on diverting people from what they could do, is actually focused on engagement of occupation and helping our people that we're looking after to look at the actual journey, the actual doing. And you know what? That might give some physiological change. I don't know the answer to this question yet. My itch hasn't been fully scratched. But I'm hoping that I'll be able to come to you in time after doing the study where we're going to take on 6 cases. The intervention starts in January, and we're going to do a 6-week period of rehabilitation with 6 people with mild to moderate symptomology within North Wales. We're going to do a 6-week period of rehabilitation, and we're going to see if there's any progress or if there's any plateau of symptoms and see how they have felt about how that's gone. I think it's certainly worth a try.
Thank you. Any questions for Helen? Yeah. And then out the back. Sarah, you go.
When you do the study, are you going to have 6 people that you follow that receive, say, regular interventions? So
The 6 people will still have the statutory intervention, so they'll still have normal interventions. They'll all be known to an OT. They'll probably have a compensational aspect provided to them as well.
to the same people? You won't have a separate, will you have a separate group?
No, we're not going
like
to have a separate group where there is a do nothing, not at this stage. We're going for the 6 to see how does it work with the 6. At a later stage, we might do separate.
Up the back.
Hi, thank you. That's excellent. Emily Plowman from University of South Florida. I'm a speech-language pathologist, and I absolutely share your opinions very enthusiastically. We've been doing expiratory muscle strength training to work on airway protection and swallowing. And we started with a small pilot study in 15 individuals. And we did a delayed intervention design where we benchmarked their bulbar disease progression and then did the intervention. And now we're doing a randomized sham control trial. But, I feel the same way for speech language pathologists. We have give them a feeding tube and an AAC device.
Yeah.
And let's just try and, help with compensations and this and that. And it's not based on any empirical data. There've only been 2 case studies to look at the impact.
I think probably, I don't know whether it's same, but within England, ALS-MND doesn't come within a rehabilitation policy, if you like, a frame. It doesn't come within those rehabilitation services. And I think that's probably why that's how therapists tend to react. I think it's worth us giving it a go to see if there can be. From what a lot of you have said, there are cases that do benefit from intervention like this.
Absolutely, and I think we just need to figure out, when
Yeah.
and how much and dosage, and we're very cautious. We get early on patients and
That's right.
very mild to moderate intensity exercise, but
That's useful you're saying, because certainly all the studies are saying not to do this in chronic symptomology. It's mild to moderate symptomology. It's actually detrimental within chronic symptomology. So you need good OT to be able to detect that hitting it at the right time.
One last question, anywhere? No? Join with me in thanking Helen for her presentation.